Okay.
So we are ready with the recording part. Chris, are you ready to present?
I am all ready.
All right. So will you be unsharing your screen first and then reshare again once you're done with your introduction part? We would want to
Uh,
capture your introduction part first on the bigger picture on the bigger screen, and then once you're done with the introduction part, then probably you can share back your PPT, and then we'll put you on a PIP mode.
Prateek, let's do one thing. Since it's
Uh-huh.
going to be a few seconds of introduction,
Okay.
so there will be more time involved in sharing and sharing the screen again. So let's
Okay.
just keep it the same format, and we will record it and we will play it as it is because it's going to
Sure.
be a
All
few
right.
seconds of introduction.
Even if it is recorded in a different format, I'll get that edited. No problem, Nikhil. All right.
Okay. Okay.
Uh,
Sure.
Chris, I'll give you a countdown of three, and then we can start. If you could please
sure.
make your presentation on a fuller screen mode.
Let me see. Oh, presenter view.
Yes,
Is
that's
that better?
perfect. Yeah.
Okay.
So we can go live in three, two, one. Chris, you're live now.
Good morning. My name is Christine Palladino, and I am a certified pediatric nurse practitioner that works in the Division of Pediatric Neurology, specifically the Pediatric Sleep Program at Cohen Children's Medical Center on Long Island, New York. I work very closely with Dr. Katari and have been working as a sleep specialist for the past 3 years. Thank you for having me. Today, I'll be speaking about the management of insomnia in children. I have no conflicts of interest. So, our learning objectives today: to be aware of insomnia in neurotypical children and children with neurodevelopmental disorders, to be knowledgeable on management strategies for treating insomnia, to be comfortable in prescribing various medications for treating insomnia in the pediatric population, and to become familiar with methods of cognitive behavioral therapy for insomnia, or CBTI. So the pathophysiology of sleep disorders, these are factors contributing to different types of sleep disorders. For example, neurobiological factors such as autism, family dynamics, sleep habits and hygiene, different medications that can be either alerting or sedating, medical disorders such as reflux, psychiatric comorbidities such as anxiety or depression, or we have our organic sleep pathologies such as obstructive sleep apnea, narcolepsy, periodic limb movements of sleep, or restless sleep. And all of these can contribute to sleep disorders, which thus cause difficulties in daytime performance. So, pathophysiology of sleep disorders. This figure here shows a relationship between sleep and circadian dysfunction in neurodevelopmental disorders. We can see here at the top that different genetic, environmental, neurobiological, or neurophysiological factors all impact sleep and circadian dysfunction by either causing synapses formation, maintenance, and plasticity in synaptic dysfunction, or difficulties in cortical development, thus leading to cognitive, behavioral, and emotional difficulties. Insomnia. So, what is the definition of insomnia? It is a predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of the following symptoms: So you may have difficulty with initiating sleep. In children, this manifests as difficulty initiating sleep without caregiver intervention. 2, maintaining sleep is difficult for the patient, characterized by frequent awakenings or problems returning to sleep after awakenings. And in children, we'll see this manifest as difficulty returning to sleep, again, without caregiver intervention, or early morning awakening with inability to return to sleep. So how do we go about making the diagnosis? According to the DSM-3, we may have sleep disturbance causing clinically significant distress or impairment in social, occupational, educational, academic, behavioral, or other important areas of functioning. These sleep difficulties occur at least 3 nights per week, present for at least 3 months, and these sleep difficulties occur despite adequate opportunity for sleep. The insomnia is not better explained by and does not occur exclusively during the course of another sleep-wake disorder, such as narcolepsy, obstructive sleep apnea, or parasomnias. And it is not caused by physiological effects of a substance, such as drug use or medication. And coexisting mental disorders and medical conditions do not adequately explain the predominant complaint of insomnia. First, we'll discuss insomnia in a neurotypical child. So in younger children, we mainly see behavioral insomnia, which is often related to learned sleep associations or inadequate sleep hygiene, which is called bedtime resistance. And it most commonly and typically responds to behavioral interventions, such as establishing consistent routines and sleep hygiene education. Now, in school-age children and adolescents, we typically see insomnia manifest as delayed sleep onset, early morning awakenings, or sleep state misperception, often linked with circadian rhythm shifts, anxiety, or comorbid conditions. The natural history indicates high persistence rates, with many children experiencing chronic symptoms that can impact mood, cognition, behavior, and overall development and performance. And risk factors include psychiatric comorbidities, family environment, and lifestyle factors such as screen time and irregular sleep schedules. Delayed sleep phase syndrome. This is not to be confused with insomnia. We commonly see it in adolescents as a circadian rhythm disorder. And these patients are our night owls. They want to go to bed after midnight and want to wake after noon. Difficulty falling asleep only when, these patients have difficulty falling asleep only when trying to sleep at socially normal times, but no difficulty falling asleep or staying asleep when the bedtime and wake up times coincide with their circadian rhythm. So behavior therapy for toddlers. So in our practice, we use the faded extinction method or the gate method. And so what we do is we guide parents in teaching them different ways to use the gate in the doorway and using a mattress on the floor as a form of sleep training. So what we do is we tell the parents at bedtime to enter the room with the child, close the gate, and do the nightly routine. Kisses, story, prayers. Once all of that is done, then the child stays in bed and the parent lays on the mattress on the floor. And the goal is to get the child to stay in their bed. Once they're there, the parent can start making their way out of the room. And so it's faded in the sense that each night we hope that the parent can get further and further away from that mattress on the floor and get the child to fall asleep on their own in their bed. If the child does wake up in the middle of the night, we do suggest that the parent comes back, but does not go into the bedroom. So they stand outside of the gate. Do not negotiate with the child. And very robotically and, as short as you can, just tell the child that you're there, you love them, reassure them, and then walk away. We tell parents it is okay if the child falls asleep on the floor next to the gate. And in the morning, wake the child at the determined wake up time to help set the body clock. We do tell parents it is a process, so it takes up to 2 weeks for the child to learn and adapt to the new way of sleeping. And this is the schedule we use for returning to comfort the child. Once the parent leaves, if the child starts crying, we tell the parent to set a 1-minute timer. And at that time, return, reassure from outside the bedroom. Then they will walk away. If the child gets upset, crying, calling for them, they'll set a timer for 3 minutes and then return and do the same thing. And this goes on and on. As you can see, the first night, the time is shorter, and then each night, the amount of time between returning increases. We do suggest using a sticker program. So in the morning, if the child did spend their night in the room, they get a sticker earning a toy or whatever they wish. Now, insomnia in children with the neurodevelopmental disorders, specifically with intellectual disability. About 30 to 60% of children with intellectual disability suffer from sleep disorders. The severity of the intellectual disability, younger age, associated cerebral palsy, and presence of epilepsy correlates with prevalence of sleep disorders. Less than 20% of families are treated for sleep problems in this population. Pathophysiology of sleep disorders with neurodevelopmental disorders. So we may have circadian misalignment, dysregulated melatonin synthesis or secretion patterns, clock gene abnormalities, abnormalities in GABA, glutamate, serotonin, or dopamine within the CNS, coexisting psychiatric comorbidities, epilepsy or GERD, or associated ritualistic behavior, sensory integration deficits, self-interest behaviors, poor communication skills, and limited responses to social cues. Contributing factors, again, may be epilepsy, anti-seizure medications, cerebral palsy, genetic factors, blindness and visual impairments, sleep disordered breathing, or psychological or behavioral factors. Now, sleep disorders primarily with autism. This is a very nice article that was written by my colleagues a few years back on the assessment and treatment of sleep disorders and abnormalities in children with autism spectrum disorder. Here in table number 1, you can see that there's many different sleep problems that can occur, such as insomnia, parasomnias, movement disorders, or circadian rhythm disorders. And the bottom table are different types of subjective assessment methods. We use primarily the Children's Sleep Habit Questionnaire, which has a nice modified version specifically for children with autism spectrum disorder. This is another article that was written, again, by a few of my colleagues in the relationship of serum ferritin levels to sleep fragmentation and periodic limb movements of sleep on polysomnography in autism spectrum disorder. So we do very routinely check ferritin levels in our practice, and we treat with iron supplementation for any low levels of ferritin. And in this article, we found the main causes of sleep disturbance in autism. To name a few: poor sleep habits, hypersensitivity to environmental stimuli, repetitive thoughts or behaviors, inability to benefit from communication, social cues, psychotropic medications is a very big one, melatonin deficiency. Now, on the left-hand side, this is a stepwise, sleep-wise approach for children with autism. Very important to establish a routine, different sensory cues, such as music, weighted blankets may be very helpful, or a massage, communication cues such as visual prompts and sequencing, reward charts. Behaviorally, we guide parents into making a timetable of sleep, may need to change the bedtime to earlier or later, restricting sleep, and again, ignoring, which is the gradual process of sleep training. And then on the right-hand side, you can see that this is a picture schedule, and this is helpful for children who respond better to visual stimuli than auditory stimuli. Now, on the left-hand side, you see the behavioral interventions that we use for insomnia and autism spectrum disorder. And this is our first line of treatment. You know, we guide parents into making sure the environment is dark, cool, quiet, non-stimulating, electronics off at least 1 hour before bedtime, keeping the sleep routine very consistent. Avoiding naps is very important, especially at least 4 hours prior to bedtime. We want to make sure bedtime's close when the child naturally falls asleep. And then on the right-hand side are our medications, which would be our second line of treatment if we've tried and failed the behavioral interventions. So we do use melatonin quite often, usually the dose up to 3 milligrams, sometimes 5 for children with autism. Iron very frequently for restless sleep at night. Alpha-2 agonists such as clonidine and guanfacine. Doxepin I will speak about. Mirtazapine we use. Gabapentin, SSRIs. We have our wake promoting medications, and that's more for patients that struggle with excessive daytime sleepiness. The benzodiazepines we don't use much due to addiction and tolerance. The non-benzos, such as Lunescence and Sonata, also are very habit forming, so we try to use them sparingly. And then you have our dual orexin receptor agonists, or our DORAs, which are newer medications that have come out. And these work wonderfully, but we do have issues with coverage for less than 18 years of age. And then absolute contraindicated is trazodone, antihistamine, and chloral hydrate. Now, this was a research study done again by my colleagues a few years ago, looking specifically at doxepin use in children with insomnia. Now, doxepin is a non-addictive tricyclic antidepressant with antihistaminic properties. And what was found is that at higher antidepressant dosing, about 75 milligrams a day or higher, doxepin inhibits serotonin and norepinephrine reuptake, as well as having anticholinergic, antihistaminergic, and anti-alpha adrenergic effects. In low doses, however, which is less than 10 milligrams a day, doxepin acts as a hypnotic, binding preferentially to H1 receptors and with no meaningful affinity for norepinephrine and serotonin receptors, thus a smaller side effect profile. They also looked at other tricyclic antidepressants, such as amitriptyline, which both worked well in improving sleep architecture by shortening sleep latency, increasing total sleep time, decreasing awakening after sleep onset, suppressing REM sleep, and improving overall sleep efficiency. However, as you can see on the left-hand side with the graph, the doxepin, which is the first graph, really only binded to that H1 receptor, which was the sedating receptor, and the other receptors much less, therefore causing far fewer side effects, as well as less morning time grogginess compared to the other tricyclic antidepressants. Now, this is our proposed algorithm for treatment of pediatric insomnia. So when a patient comes in and has been diagnosed with insomnia, we are looking again at medical or surgical causes of insomnia, such as restless leg syndrome, periodic movements of sleep, or obstructive sleep apnea. Now there we will either refer to ENT if we're looking for a cause of upper airway resistance, or do a polysomnography to rule out obstructive sleep apnea. And we'll check the ferritin levels, and anything less than 50 to 75, we do treat with about 3 to 6 kilograms per milligrams per day of the iron supplement. Now, our first line of treatment again is the behavioral interventions plus 3 milligrams of melatonin. If there is symptom resolution, we will continue with that, reinforce intervention, continue melatonin. If there is no resolution, then we start with doxepin 2 milligrams, and we increase every 3 days to a maximum dose of 10 milligrams. Now, these are some tools for sleep, behavioral, and emotional assessments that we use specifically for children with neurodevelopmental disorders. To highlight a few that we use in our practice, the Bear Sleep Screening Tool, the Morningness Eveningness Scale for children, the Child Behavior Checklist, and the Autism Behavior Checklist. So varying ages, varying cognition levels can all be really tested using these screening tools. And these are 4 very good research articles as well that all look in sleep and circadian disturbances, specifically in neurodevelopmental disorders. This is another one that was done by Dr. Kothari and one of our colleagues, Dr. Pavkovic, looking at the pharmacological approach to insomnia. And now I will speak on cognitive behavioral therapy for insomnia. So cognitive behavioral therapy for insomnia focuses on exploring the connection between the way we think, the things we do, and how we sleep. The cognitive intervention piece to it helps to change inaccurate or unhelpful thoughts about sleep. The behavioral intervention works on controlling stimulus before bedtime, sleep restriction and compression, and incorporating relaxation techniques to help establish healthy pre-sleep habits. And then the psychoeducational intervention piece is providing information about the connection between our thoughts, feelings, behaviors, and sleep. So to discuss stimulus control, this aims to strengthen the association between your bed and sleep and weaken the association between your bed and wakefulness. So we tell patients to set a consistent sleep schedule. Very important to go to bed and wake up at the same time every day, even on the weekends, to regulate your body's natural sleep-wake cycle. To use your bed only for sleep in the pediatric population. Avoid watching TV, reading, doing homework, talking to friends, using electronic devices in bed. If you cannot fall asleep and you have not fallen asleep within 20 minutes, we suggest getting out of bed and do a relaxing activity in dim light in another room until you feel sleepy. Then return to bed and repeat as needed until you fall asleep. And importantly, avoid daytime napping, as naps can disrupt your sleep schedule, especially if they're long or late in the day. And if we must nap, we do suggest keeping it short, about 20 to 30 minutes, and early in the afternoon. Sleep restriction therapy. This involves limiting the time you spend in bed to the amount of time you're actually sleeping. And this is to consolidate sleep and reduce time spent awake in bed. So we tell patients to calculate the sleep efficiency, so tracking sleep patterns for about a week and determining how much time of that you actually are sleeping versus just spending in bed. And then restrict your time in bed. So initially limit your time in bed to the average number of hours you've been sleeping, and then gradually increases time as your sleep improves. Very importantly, maintaining a consistent wake-up time. So even if you've had a very, very poor night's sleep, still wake up at your designated time to maintain your sleep schedule. Different forms of relaxation techniques. These techniques help to calm your mind and body, making it easier to fall asleep. So one is the progressive muscle relaxation. This is tensing and releasing different muscle groups in your body, starting with your toes and working your way up. Deep breathing techniques such as slow, deep breaths, helping to reduce stress and promote relaxation. Meditation or mindfulness. We always tell patients to think of or make a story in their head of a calming image or a happy time, and guided imagery, visualizing peaceful scenes, relaxing your mind and body. So cognitive therapy. This addresses negative thoughts and beliefs about sleep. So it's important to identify and challenge negative thoughts. So if you find yourself worrying about not being able to sleep, challenge those thoughts by asking yourself if they're realistic and helpful. And then replace those negative thoughts with positive affirmation. So instead of focusing on not being able to sleep, try focusing on positive statements. And reframing sleeplessness. So if you cannot sleep, try to view it as an opportunity to then just rest and relax in bed rather than it being a problem. Sleep hygiene education. This involves learning about healthy sleep habits. So the importance of creating a relaxing bedtime routine and engaging in calming activities before bed, such as taking a warm bath, reading a book, listening to music. I tell patients to maybe use a sound machine or listen to a podcast. Again, very important not to use the electronics or looking at the screen for at least an hour before bedtime. Optimize your sleep environment, making sure your bedroom's dark, quiet, and cool. Avoid caffeine and alcohol before bed, as these substances can interfere with sleep. Get regular exercise, as physical activity can improve sleep quality, but avoid exercising too close to bedtime as well. And then expose yourself to natural light during the day. As we know, sunlight helps to regulate your body's natural sleep-wake cycle. So in conclusion, sleep disorders are very common in neurotypical and various neurodevelopmental disorders. Behavioral therapy should be the first line of treatment, and the in treating insomnia in pediatric patients. And cognitive behavioral therapy for insomnia focuses on exploring the connection between the way we think, the things we do, and how we sleep. Lastly, cognitive behavioral therapy for insomnia with medications achieves the best results. Thank you so much.
Thank you, Ms. Palladino, for the presentation. I think it went quite well. Vivek, can you tell me that you captured the entire presentation?
Yes, sir. I have captured it.
Okay, so is there anything that needs to be done now?
No, no, all is done from my side.
All is done from your side. Okay, that's great. So yes, Ms. Palladino, we are through with the recording of the presentation, and now we will download it and we will, edit it as per our, required format, and then we will play it during the Congress. And we will also share the Zoom link. So just you will have to be available at the time when we are doing, the Q&A rounds after the presentation is over.
Okay, wonderful. And that will all be in the time of that will all be in the email, just because I know it's the 9-hour difference here. I just want to make sure I get the time exactly.
Yes, absolutely. So what we will do, we will tell you the, I think it's EST, right? New York?
Yes.
Okay, so we will give you the time both in EST and in IST based on when the session has been, scheduled.
Okay, great.
Yeah, we will do that.
Wonderful.
Okay, thank you for making time for us and doing the recording. And I can't say we look forward to welcoming you because we will be playing it recorded. So we look forward to have you for the Q&A, live Q&A.
Thank you so much for having me. It's nice to meet you.
Same here. Thank
you. Bye-bye.
Bye. विवेक, कितने मिनट की प्रेजेंटेशन हुई थी टोटल?
हेलो, वन सेकेंड चेक करता हूँ।
टोटल नहीं, मतलब इन्होंने कितनी देर किया था? कुछ स्टॉप वॉच लगाया था हमने या टाइमर वगैरह कुछ लगाया था?
नहीं, ऐसा तो नहीं, बाकी रिकॉर्डिंग टाइम से मैं बता सकता हूँ एक्चुअली।
एक बार देख के बताना। 25 मिनट से ज्यादा नहीं होना चाहिए।
ठीक है, 25 के अराउंड ही है।
25 के अराउंड है?
हाँ, 25 के अराउंड ही है।
ओके, चलो फिर तो ठीक है, आई थिंक। ठीक है, थैंक यू विवेक। अभी मैं एक फैकल्टी की शायद और होगी रिकॉर्डिंग, तो वो शायद संडे को या फिर मंडे को बोल रहे हैं, एंड थोड़ा पहले ही बोल रहे हैं, मतलब 8:30 से पहले। आई थिंक वो संडे को बोल रहे हैं 9 बजे। हाँ नहीं, सॉरी, 9 बजे उनके टाइम, तो हमारे 2 घंटे और पहले हो गए ना। अभी उनके 11 बजे का, तो 6:30 हो गया शाम का। ठीक है, 6:30 या फिर मंडे को 7:15 बोल रहे हैं। मैं एक बार प्रवीण से डिस्कस कर लेता हूँ एंड देन उसके बाद भी